Hello, I'm Dr. Gaye Carlson, President of the American Academy of Child and Adolescent Psychiatry, with number 25 of my Screenside chats for our AACAP members. My goal with the chats is to share timely clinical practice and other information from experts on key topics during the COVID-19 pandemic continuing to plague us. Reminiscent of President Roosevelt's fireside chats during the Great Depression and World War II, I wanted the topics to be informative, timely, and comfortable, fill a niche not addressed by materials otherwise available. So today's topic continues the theme of what I call the other pandemic, and how child and adolescent psychiatrists are addressing the huge increase of emergency patients that are being reported nationally and internationally. I've asked my Long Island neighbor and longtime friend, Dr. Victor Fornari, to tell us some of the ways in which Northwell child psychiatry is problem solving. Dr. Fornari is in a good position to do that. He's professor of the Departments of Psychiatry and Pediatrics at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell, and vice president and director of the Division of Child and Adolescent Psychiatry at Zucker Hillside Hospital. It's a position that he's held for the past 12 years. Dr. Fornari is actually used to disasters, having developed a response to the AACAP plane crash in 1990. He was part of the mental health response to the 9/11 Project Liberty and participated in the response to Hurricane Sandy with Project Coast. He helped develop and co-lead Project Teach, which is a New York State Office of Mental Health initiative to support primary care physicians to care for mild and moderate mental health concerns of children and adolescents. So welcome, Victor.
Thank you. Good morning, and thank you for inviting me.
So you've been busy over there at Northwell. Tell us what your experience has been over the past 12 months with COVID regarding the kids that you've been seeing.
Well, for everyone, figuring out how to transform our clinical services during the pandemic was really initiation by fire. And virtually within 1 week, we developed and transformed our clinical services to try to be in compliance with guidance to minimize the spread of infection. So our ambulatory service really switched to all telehealth. And all of our staff and faculty had a very quick fellowship in telemedicine and learning.
I think everybody did that. Something that took 10 years to achieve. We got done in 3 days.
Absolutely. If someone were to have told us the year before that we would be practicing telehealth, including evaluation, safety planning, I would not have really believed it, but we transformed the service here, and it's been extremely effective. The emergency services included even having clinicians do telehealth from home of emergency room patients. Inpatient care included even the physicians being in their offices. And so we really utilized telehealth to try to provide continuous care, but also to protect the faculty and the staff as much as possible. I think the most striking thing has been the enormous increase in volume. And at a time when all of us have been concerned about our own safety, the safety of our family and friends, our colleagues, our staff, we found ourselves working harder than ever, trying to meet the need, which has been enormous.
So just to finish up your first comment about the switch to telehealth, where are you now with that? Is everybody still completely telehealth? Are some of your services back to partly in person? Does it depend on the kid? Does it depend on the service? Where are you back to in your normalcy route?
Right, so I think we have the full spectrum. Many staff continue to work from home, exclusively telehealth for their ambulatory cases. The pediatric consultation CL service is now fully face-to-face. The inpatient adolescent and child service is fully face-to-face with clinicians using their protective gear. The ambulatory service on different sites is variable. So at the Zucker Hillside site, the Child and Adolescent Psychiatry program continues to be fully virtual with a hybrid of some staff working on site but seeing their patients via telehealth, and the majority of staff and faculty working from home seeing their patients via telehealth. On another site, we have the clinicians and the patients coming in. So we have a hybrid, and we're really trying to transition staff back in while they continue to see their patients via telehealth in order to desensitize them to being back in the workspace, and probably do it 2 days a week per staff member to kind of get them back in the groove of returning to the office.
So that's the ultimate goal, is everybody back in their offices?
Well, we think that for now, as long as the regulatory bodies and the reimbursement agencies and insurance companies will fund it, we probably will continue with a hybrid of services such that there will be a certain amount that will be provided face-to-face, but the telehealth will really remain for a significant portion of our ambulatory services, because we found that for many families it really has been an enormous boost because of the access to services. Distance is no longer an issue, parking, traffic, babysitting. And so for many families, this has really been an excellent way for them to continue to have the care for their children and family. For certain clinical situations, we may choose to have it face-to-face, and we may prioritize that for new evaluations, for high-risk cases, for patients who we need to take height, weight, and vital signs for. We may have interval visits that are face-to-face perhaps every 3 months in order to be in compliance with some of the metabolic screening and parameters that we monitor for their physical health. And so I think that over time, what the landscape will look like really will depend upon a number of factors, including what the regulatory bodies and the reimbursement insurance companies will allow.
So what have you and Vera Foyer been doing in terms of your emergency services? You were saying a few minutes ago about how much of an increase there has been, and that seems to be not just in the United States, or not just on Long Island, but in the United States and internationally. So what have you been doing?
Well, I think at the same time that the pandemic was unfolding, the emergency psychiatric services for children and adolescents were expanding, and including the development of urgent care centers, not attached to an emergency room, but were in the community. And so I think we've continued that so that we have urgent care available walk-in Monday through Friday, 9 a.m. to 4 p.m., as long as they're accompanied by a parent and they're not brought in by ambulance. And they can be seen by a child and adolescent psychiatrist on a walk-in basis. And our urgent care system over the course of the pandemic in the last 12 months has been equally as busy as our emergency room. So we've seen over 2,000 visits just in the walk-in urgent care, and over 2,000 visits in the emergency room. So the previous year, we probably had close to 4,000 visits in the emergency room alone. And this has really been a tremendous boost to try to minimize the use of the emergency room unless it's medically necessary, but still to be able to provide urgent access for children and adolescents' mental health on really an immediate basis. So I think we've seen the dramatic increase of urgent care and the provision of walk-ins that has been tremendous.
So what comprises urgent care versus emergency room care? And it seems to me that the bottleneck isn't just, can you see somebody right away, but what can you do with them after you see them? That seems to me the real bottleneck.
Well, I think we were trying to see, how do we understand who really requires the emergency room? And I think that the severity of safety concerns usually is the determining factor. But anybody who's brought in by the police or an ambulance goes to an emergency room. And usually there's been either some serious aggression or self-harm that has led to calling 911. Any child or adolescent who's brought in to the emergency room without a parent goes to the emergency room, not to urgent care. And
so if some child makes a threat or does something really troubling in school or whatever, and the school says you need to go to the emergency room, and I guess they have to get there by ambulance because otherwise a parent has to take them there. That goes to the emergency room.
Well, actually, we've been working very closely with the school districts surrounding our health system, and we've tried to work it out so that they can really come to urgent care by having notification of the parent and the parent accompanying them. Mm-hmm. The emergency room would be used only if the parent is not available, can't be reached, then they would go to the emergency room. So the urgent care really has been utilized for schools, and we've seen that the admission rate from urgent care is quite low. Mm-hmm. It's as low as 5%, where from the emergency room, it may be around 20%. Now, nationally, we know that admissions from psychiatric emergency rooms for youth is significantly higher. And oftentimes that's because the expertise in the emergency room is not a child and adolescent psychiatrist, and either it's a general psychiatrist, a resident, or other mental health professional, and they're often admitted because the risk assessment is felt to be something that they're not comfortable with. And I think having an attending faculty in the emergency room as well as in urgent care has really been a very critical factor in allowing us to feel that we can provide those emergency and urgent care consultations with a sense of comfort that the safety planning can be done and determining who really requires hospitalization. At the same time, the other thing I just wanted to add, in addition to the urgent care, we built in, and this has been really under the leadership of Vera Foyer, the capacity for linkage in urgent care so that children and families could continue there until they made linkage in an outpatient facility in the community. So if we saw a child in urgent care yesterday and we couldn't get linkage for 2 weeks in an ambulatory service, they could come back for scheduled appointments in urgent care to follow them closely until they make linkage. The other thing we did in our own ambulatory services, we converted the intake system for anyone who was seen in the emergency room or urgent care could get an open access appointment the same week. So we really tried to minimize the bottleneck of getting into an ambulatory service, because in many regions of the country, the reason why youth are hospitalized is that it can be virtually months before they can make an appointment into an ambulatory service, and that would not be safe.
Yeah.
And so I think...
And that's why I said that the bottleneck almost isn't getting the person into an emergency or urgent care. The problem is getting them out. And so right. that's where we get into the boarding business. And I've wondered how many of the people that are boarders really need to be in a hospital. I mean, I think there's a question of the liability part of it. There's some of the question is clearly the child has significant needs. And I think sometimes it's like you don't know what else to do. And so that's what the reflexive response is.
Well, I think in our system, we have tried to minimize boarding, and boarding really has only been in our situation where there are no beds available in the community for youth that are deemed to require inpatient psychiatric admission. I think because of the development of open access to ambulatory services, as well as to be able to have rapid follow-up and urgent care the next day or same day, we've really been able to just make the boarders or individuals who have deemed to be required to have inpatient care, and there's simply no beds in the community. And there's been a shift. In the past, many of those children and adolescents were admitted to pediatrics to be boarded in the hospital and kept on a one-to-one. We've really tried to minimize that in collaboration with our children's hospital, and so the youth are now boarded in our locked child and adolescent psychiatric emergency room. The problem is it's very tight space. So it's really not optimal to have a child or adolescent there for a prolonged period of time. And so we really work very hard to try to minimize the boarding except when it's absolutely necessary.
Yeah. Didn't you also say to me that you expanded your beds at South Oaks, or I don't one of the nearby hospitals?
I think certainly in response to the dramatic increase in suicidal presentations to our emergency services and urgent care, we found that probably about a 30% increase in the numbers of youth presenting to our services for suicidal behavior. And that's in keeping with what I understand has been seen throughout the country. And what we ended up doing is that we found that we had such a large number of youth requiring hospitalization that we transformed one general psychiatry unit into an additional adolescent unit, so that we had an extra 25 beds above what our usual.
That was really it was good that you were able to do that, because I think that there's a general consensus that we have lost. I mean, I think, yes, we need to have better alternatives than hospitalization, but we've lost a lot of beds over the last 10 to 20 years, and we're feeling that pinch. Let's change the subject a little bit, and let's talk about what the impact of COVID has been on the kids. Do you think there's been any particular impact to the social distancing, the quarantining, the face masks? Do you think that there's been any, you were telling me before about how important you think resilience is. Do you think there's been any silver linings to any of this that has helped our young people?
Well, certainly the pandemic has demonstrated what we've known in terms of child's mental health, that when children grow up in families where their parents have good mental health and don't have active substance abuse or domestic violence, the children do better. And I think during the pandemic, families are stressed, so that parents themselves are anxious and depressed. They've had financial hardship, they've lost jobs, they've had increase in substance use. And so children are growing up in environments exposed to parents who are more anxious, more depressed, with more conflict. And it has really not been typical that families would be living together 24/7 during the quarantine. Children usually went to school, parents went to work or stayed home. And when the children were at school, they had their friends, their activities, and their social outlet. I think during the pandemic, kids really experienced the stresses of their families as well as their own stress. And so I think what we have seen in the pandemic is that parents, adults who've been able to manage their own anxiety, manage their own level of sadness or depression, really have been very helpful. Now, I know it's hard, and so many families have struggled, but I think the best lessons from the pandemic, I hope, will be those really wonderful acts of courage and selflessness that so many people have displayed. I think in a time like this, you see the best of humanity, and I think those examples are, I hope, what we'll learn from and what will be written about, and the stories that will be told about some of the really selfless and acts of courage that so many people have engaged in during the pandemic.
So have you had much fussing about, or I don't know, I mean, our community at Stony Brook, I don't think we've had a lot of issues with with mask wearing or social distancing. I think people have been pretty compliant with it, but we're a university community, so I guess I'm not surprised. What about further west of here?
Well, I think that for the most part in our region, and certainly in our health system, and our experience has been that people have worn face masks, done social distancing, and tried to follow the guidance. I think, as in many places, we've seen that some people really aren't quite convinced that this is necessary. They may not believe that the pandemic is as contagious and as potentially dangerous as it is. And so I think we've worked very hard in our health system and to make sure that here all the staff, the faculty, the patients, everyone has to wear face masks, practice social distancing, use the PPE properly, and try to mitigate the infection. I think the hardest part for the hospital care has been the lack of ability to have in-person family meetings and visiting, which is such an important part of the child's inpatient hospital stay. And so that's been very difficult, but I think it's really been at the expense of trying to prevent infection. And so we've just begun reopening visiting again to allow one parent or guardian to visit for 1 hour, provided that they meet certain guidelines to make sure that they're in good health. But I think that in general, our experience has been that people have been following the guidance.
So we were talking yesterday at our faculty meeting about what role we have, if any, in terms of helping with vaccine hesitancy. And I know my personal approach is when I see people, and I am seeing people increasingly in person, I just can't, for more difficult kids, I just have a really hard time relating to them virtually. I need to see the kid, right? Anyway, when I see the child and the parent, I sort of have a little ritual, which is I hold their hand out, I give them a squirt of hand sanitizer, and I say in a nice, friendly way, have you been vaccinated? And I have to tell you, 9 times out of 10, the answer is yes. Well, maybe 8 times out of 10, the answer is yes. One time is that they're waiting for their appointments or whatever, and one time is no. And so then the question is, well, what do you do with the no's? And at least what I do with the no's is basically say, are there any questions I can help you with on the subject? I'm not going to spend my evaluation done arm wrestling them about getting a shot. But it does seem like it's an opportunity to have somebody that maybe develop a relationship with you to be able to answer questions. So I wondered how you were handling that.
Right. So in our health system, we've been providing some community education on Zoom, where we have public service time where we have conversations. I've done several of these, and other faculty member, to try to answer questions about concerns about the vaccination process, concerns about potential risks from the vaccine that people have, to try to dispel some of the myths that are circulating on the internet about some of the issues that are inaccurate about either the vaccine or about COVID-19 as a virus. And so I think community education has been something we've tried to provide, and to continue to understand that for many people, this is really a reaction to a lack of trust based on earlier experiments where certain groups really were discriminated against, and a mistrust of experimentation and research. And so we try to educate about how today we try to work very closely with our institutional review boards to protect human subjects, and that some of the inappropriate and really abusive procedures that occurred in the past, which are shameful, we understand the reluctance, but we hope that people accept that this is what we're doing today. And I tell everybody we wear proudly a pin that says I've been vaccinated, and we have stickers on our ID badges. And I think we want to make sure people understand that we feel it's safe, and we think it's medically necessary for ourselves, and the very vast majority of our faculty, physician and nursing staff have been vaccinated. It's over 95%. However, many of our other employees have been reluctant, and they want to wait longer, or they're not sure they trust it. And so we continue to work with our own staff throughout the health system to educate the people who are still reluctant to accept the vaccine, particularly because they're in a position to be exposed to the public so much. And so we really hope that they will, over time, accept it, as I hope the general population will as well.
So speaking of your staff and faculty, how much stress have they been under? How have you been able to help your colleagues, or what kinds of supports have you built into your system to help your colleagues? It sounds like you're sort of desensitizing them coming back to work, which suggests that there's some reluctance and so forth. So what have you found there so far?
Well, much like with every disaster or every traumatic experience, our staff and faculty have experienced the full range of experiences. Many have had COVID-19 themselves. Some have been seriously ill and hospitalized. Some have lost family members. Many have been home trying to work while caring for kids who have been on home instruction with virtual education. And many their spouses may have lost a job. So many of the staff and family members have been very impacted by COVID. And throughout the pandemic, we've tried to maintain at first a daily check-in for half an hour with all the staff and faculty to provide updated education, information as we learned it, update about changes that were happening in terms of work procedures and policies. And then as things settled a bit, they became weekly meetings, which continued. We reached out and learned about who was more impacted, the individuals who themselves were physically ill or had loved ones who were physically ill, and tried to reach out individually in a very human way because we're colleagues and co-workers, and tried to make sure that everybody was in contact to be as supportive to the staff and the faculty as we could. It's been challenging. It's been hard to teach virtually. We haven't had our trainees in the same room throughout the whole year. Supervision is on Zoom. Periodically, I bump into somebody in the emergency room in the lobby, and I say, well, I'm so happy to see you. It's so wonderful to see you. Last night, I went to the first retirement dinner, face-to-face, in person. I wasn't going to go. I was going to contribute to the gift, and then I realized it was somebody I really cared for, and then I thought I'd go for a few minutes, and then I stayed, and the tables were surrounded by plexiglass dividers, and I knew the people sitting at my table were also vaccinated, and so, I too felt like, I want to mitigate my own risk. But the other thing we've done, and I think in each group it's been different, we've tried to organize some kinds of activities. So, for example, the team meetings that would meet regularly, we've incorporated a mindfulness activity for the first few minutes of each group. We try to include some kind of recreation. So one team, we hired a company and we did a virtual painting class. And so we shipped everybody's home a painting set, and then we all went on Zoom for a 2-hour painting class, and we all painted the same painting that the instructor
paints.
And so we did that painting activity, and we laughed so hard. It was such a great time. And now we're planning an activity with planning to plant indoor terrariums. And so we're going to ship to everybody the necessary things that they'll need, and then we'll have a garden expert help us plant a small indoor terrarium that everybody can have. So we're trying to do some activities together. I hope that we'll be able in good weather to do some things outdoors together, but many people are still reluctant, and so we've tried to do that the best we can. This past Tuesday, we had a team meeting on Zoom with about 20 team members, and the mindfulness activity was to laugh. And then the goal was to imitate the laughter of the person before you. I want to tell you, that laughter was the best medicine. And so I think we're trying the best we can to support people's sense of optimism, resilience, remind everyone that we are all going to get through this together, that the lessons learned will be powerful lessons that we'll tell our future generations, and that, we'll have many stories to tell because everyone has had such diverse experiences. And I just recently published a reflection thinking about my own childhood. I called it Childhood Memories. And this pandemic reminded me that all 4 of my grandparents had grown up during the pandemic of the Spanish flu in 1918, 1919, because they all came from Italy. And one of my grandparents, my mother's mother, my maternal grandmother, had the Spanish flu herself and was very seriously ill. And it wasn't until the pandemic this year that I remembered some of the things that they told me as a child 50 years ago or more about their own experience growing up in the pandemic. And so
you'll have stories to tell and And I think it's kind of a nice note to end this on, because what you're saying basically is we will try to weave this into our fabric of existence, and of something that maybe we can look back on and not, God knows, not think of it with any great deal of fondness, but at least to find something that we can hang on to, that possibly that we have learned from.
Right, and I've told children that I see in my practice, I said, keep a diary, write down your experience, because you can write a college essay about this, you can write a paper in college, you'll tell your children about it. And so in my own personal reflection that just got published recently called Childhood Memories, I ended it by saying, what will a face mask mean in 25 or 50 years? What will our children and grandchildren learn about what social distancing represented? And there will be a meaning. It will be different to each person, because each person today is having a different experience during the pandemic, just based on how they were impacted directly or indirectly. And so I think the lessons learned and the optimism that, pandemics have occurred in the past, and we have to follow the guidance and be wise and do the right thing, and that we're all going to get through it together.
That is a good note to end it on, Dr. Fornari. It's been really nice talking to you. I'm sorry that it's virtual, given the fact that we don't live that far apart. But I look forward to an occasion when we can have a good laugh together. And I will wish a good laugh to our colleagues at AACAP, who I hope will be watching this at some point. So thanks, Victor.
Thank you.
Thank you all. Thank you all very much for tuning in. This is Gaye Carlson for AACAP's Screenside Chats.
AACAP provides Screenside Chats as a member in public service, but it is neither a legal interpretation nor a statement of AACAP policy. Reference to any specific product or entity does not constitute an endorsement or recommendation by AACAP. The views expressed by guests are their own, and their participation in Screenside Chats does not imply an endorsement of them or any entity they represent. Views and opinions expressed by guests are their own and do not necessarily reflect the views of AACAP or any of its officials.